Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to once again partner with Drs. Margot Adams Larson and Sarah Smucker Barnwell to present these telehealth community chats. They've done a tremendous job with this series, and I know I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. In the interest of time, I've placed their bios on a slide for you. I hope you enjoy and benefit from our telehealth chat today. Please join me in welcoming our esteemed presenters.
Thank you so much, Dr. Martin. And thank you to the Trust for having us here today. And thank you to everyone for coming. We so appreciate you spending your time with us. It's your most valuable resource, so thank you. I'm Sarah Smucker Barnwell. I'm a licensed clinical psychologist in Washington State.
And I'm Margot Adams Larson. I'm a licensed psychologist in North Dakota. And I am so excited to be here with you, Sarah, and with all of you online to bring back some further conversation about where we're going with telehealth and our communities. So
absolutely. So, this is our anniversary edition. We realize that we have been doing these updates for a year older, perhaps hopefully wiser. And as always, we'll begin with our disclosures and our conflicts of interest. We always like to say that whenever giving a presentation about technology, something inevitably with your technology will go amiss. It is just Murphy's Law. And that, I think our other disclosure is that we in our professional lives do offer telehealth training. And so you could say we have a vested interest in telehealth being wildly successful, but this is because we are both telehealth enthusiasts, sort of unabashed enthusiasts about the opportunity that this modality provides us to deliver good quality care that you all provide to your patients in accessible, scalable fashions. So on our next slide, we start talking a little bit about what are these telehealth community chats, and I'll hand it over to Margot.
Fantastic. Well, we've morphed over the past year from maybe much more frequent to now quarterly, which it feels quite right at this point to kind of think about the pace at which things are changing in our telehealth community and kind of the needs that we have moving forward for updating and all of those kinds of things. So we endeavored to have continued conversations related to practical guidance for telepsychology, for clinical concerns that arise through this new era we're living in, the regulatory environment changes, and also some ethical considerations in all of those conversations. So we have the telehealth community at trustinsurance.com email that you're welcome in between these times to email us questions or conundrums that you're having, and we'll do a little investigation and bring those to our next conversation. But for today, using the Q&A, we'll be able to monitor the questions that are coming in. We can see those and we'll be answering those along the way. So, really hoping to give some practical consideration to the topics that are before us. And as we kind of get rolling today, we're just going to show our slides for those who haven't been on before, just with the agenda. We don't really have a whole series of information on the slides. We do have a resource slide that'll be available, and a copy of the slides will be available afterwards, so you can grab those later after our conversation. Today's topics, we're talking about reflecting on the practice this past year, things that have changed or maybe not changed, thinking towards the future of practice, and also thinking about elements of our old kind of olden day practice from a year ago and what we want to return to. And then also thinking about some of those kind of insurance carrier requirements that we've seen popping up through this year. As always, we'll be taking live questions and hopefully really kind of diving into some of the things that are on everybody's mind at this point. So we do have a resource slide we've shown in the past. I'll update folks that I did add one item on there before we get rolling, and that's just a lot more information to links for the SIPAC interjurisdictional telepsychology information. And I actually put the link for the asppp.net page on telepsychology, which has a lot of frequently asked questions about interjurisdictional practice and about the SIPAC. And there's a link on that page to go out to find out a lot more information about the SIPAC. And I have a few updates I'll share as we go through today, but that's where you can find more of that information. So I guess without further ado, Sarah, I'm going to stop sharing the slides so I can see you a little bit better. Really, I think we've selected a variety of conversations today that I'm really excited to chat with you about, because I know a lot of our colleagues have been asking these questions too about kind of what did we learn this past year, and what are some of the hot topics that folks have been thinking about?
Absolutely. I always ask my daughter, and what did you learn? You know, a year ago, we really had such in my career, I think, unprecedented demand to change the manner in which we practice. And I can even say, as someone who's had telehealth in her professional milieu for many years, I mean, what a radical departure from business as usual. And many of my colleagues, you know, had no telehealth in their repertoire and very rapidly were asked to onboard some or perhaps all telehealth into their practice. And I think we saw this mean a diversity of things, and reflecting a year later, a really rapid growth in new skills and new practices. And Margo, I knew you and I brainstormed about some of the domains, and so I hope to spend some time together sort of speaking about some of them. You know, first, this concept of balancing business with, you know, our professional life with our personal life, perhaps our family life, and finding this capacity to find the balance. You know, some of us have been working within our own homes or home offices. Some of us have been working in our professional offices, but incorporating a portion or exclusively telehealth. And what this has meant for our personal and professional life, as well as that of our clients. You know, we had the elimination of commutes to the office, and in many instances, the elimination of childcare availability. And I think for many of us, this meant, you know, some very practical things, such as reorganizing our homes and our spaces, our professional workspaces to facilitate distance, to facilitate the right level of internet. Additionally, reorganizing our schedule to facilitate what that meant for childcare, both for ourselves as well as for our patients. And so why am I bringing this up? We all know this. You know, what I will say is, what is old will be made new again. That is my prediction for the period of time to come. I feel like this is what we learned, was the necessity of being flexible, of managing our own work-life balance, our own, you know, creating a professional environment, perhaps in our home, helping our patients find an environment in which care was appropriate. Right now, we are seeing people returning to work. You know, we are seeing some children returning to school, some are, some aren't. You know, I think we need to be prepared to shift again. I think we're about to, again, over the next, let's say 3 to 6 months, see changes in our schedules, changes in our patients' schedules, changes in childcare demands. I know here in Seattle, the public school is now going several days a week for 2 to 3 hours at a time. Which means something in terms of people's ability to make their appointments, to be at work, and so forth. And so I think we can expect to see sort of a similar wave of change coming up, reorganization of that clinical calendar, reconfiguration of the personal and professional lives. But hey, we've been doing this for the last year, so I feel personally a little more adept at that than I did a year ago. So I hope others do too. And, you know, this starts to get into the theme of new skills. You know, I think I may not have begun the pandemic with a feeling of really clinical expertise in themes of anxiety, health anxiety, isolation, and grief. But now, you know, I feel a little more practiced in these themes, and that's sort of a dumb joke, but, you know, more poignantly, you know, a year ago, many of us may not have thought of ourselves as telemental health provider. We might not have thought of ourselves as a telepsychologist, but there's a good chance many of us now do. And I know, Margo, it's long been yours and my contention that this skill set, you know, it is it's a big learning curve initially, but very quickly people catch up. And once they really get that comfort and that capacity to move forward. So, I mean, I think congratulations. Now we're all telemental health providers, often to some extent, whether we've been giving video sessions, whether we've been communicating asynchronously through email, chat, secure chats, secure text, whether we have been giving telephone sessions. So I think there's this, that won't change for us moving forward. There's this concept of what do we want practice to look like in the future? Will we continue to have telehealth be a portion of our practice? What do our patients want? You know, and really thinking about where do we want to grow next? Is there a specialty now that you foundationally have some skills around being a telemental health provider? And if you're sitting at home and saying, no, I don't feel that way, please go back to prior chats where we really go over some of those fundamental skills. But where do we want to grow next? Is there a training you want, a clinical subspecialty within telehealth that you would have the opportunity, sort of the sandbox to play within this milieu? You know, is there a small practice that you want to try? I know at one point in my career, I had an assessment practice. Is this something that, you know, you want to continue to develop? I think assessment is a particularly salient opportunity because this has been an area where we've had a lot of questions and a lot of growth. About a year ago, American Psychological Association gave us guidance, pain test security, you know, to do our best with the tests we had, while, you know, really safeguarding data quality, thinking about how we get good quality observational data in these telehealth environments where there's less opportunity to capture it, to think critically about what matters in the circumstance, to widen our confidence intervals in diagnosis, to acknowledge the knowledge gap that we possess, and above all, to maintain ethics. And I think, you know, that was really helpful guidance and challenging too, because I think a lot of times a lot was left to our practice and our discernment in this burgeoning area. And so I think what we're going to see in the next 3 to 6 months here a year later is we're now starting to see some publishers of administration of measures offer self-report online versions. I'm thinking of a self-report online version of the SCID. I'm thinking of, you know, online administration of the PHQ and the GAD. Like, these things are now being more formally administered. We're going to start to see norms published for the online environment. And
It
so
really has been a tremendous growth time.
unbelievable.
Yeah. And I think you and I have both, you know, talked about this previously. This has been a year of social experiment that we could never really have ever run the social experiment because the IRB would never allow this, but we're living it. So, you know, it's really brought a lot of these concepts, I think, that perhaps we could have prepared and planned and maybe had a lot more conversation about. I'm thinking particularly about work-life balance and kind of the things we had kind of clocked away to routine that really didn't work well when we brought it home and everything's contained in our home and there just is no time or separation. And I think these are all such important concepts to continue conversations on.
Absolutely. I mean, and I think about it in terms of the clinical boundaries as well. You know, we are living through this wild time. It's bananas, you know, at the same time as our clients live through it. And I think that for me, it has been a really interesting area to examine themes of transference and countertransference and, you know, really maintaining those boundaries, because, you know, clinically, when you are going through the same thing, it is deeply relatable, and thinking about how we keep those therapeutic boundaries in addition to those work-life boundaries. And I think especially as we see people return to varying levels of activity, because this is very personal, it is idiosyncratic. It may, you know, hinge on themes like what's going on regionally. It may hinge on themes like vaccination status or health status. You know, I know that my level of conservatism around COVID precautions at this point in time may differ from those of my clients. And I think it's going to be a challenge for us to be thinking about this as we contemplate the return to in-person care, when it's right for us, when it's right for patients, and I'll get into this a little later, what we're comfortable asking, what we're comfortable not asking. I mean, for me, the thing that really stands out is that telehealth will be more in the mainstream now. And I'll say as an aside, it is, you know, if you haven't yet made the investment, if you haven't invested in that software that you think is really the good software, if you haven't invested in a really comfortable chair to sit in your home office or wherever you do telehealth from, if you haven't bought the standing desk yet, you know, like, I'm going to go ahead and say, if it's economically feasible, treat yourself. That, like, I think that this is going to stay. And
That
so
gaming chair should be on the Christmas list this
that's
year.
right. Just planning for a future, where this is a part of our clinical practice.
Yeah, I think you've raised a few points, and one of the things that resonates for me is the idea that this really is a relevant circumstance because we're all experiencing it. And I think that's one of the biggest cautions that I have in talking with colleagues is, even though this is a relevant experience and we have a shared collective global kind of experience occurring, it doesn't mean that it's the same for everyone. And you highlighted that in terms of, your thoughts of kind of what your perspective might be compared to your colleagues. But I think that's equally true in terms of with our clients. And unfortunately, because it's a relevant to everybody experience, oftentimes we have this bias that what our experience is and how we're solving it is the same, for everyone in our world. And that just, it's so important to make sure we're, particularly with our clients, making sure we're asking those important questions of what it is for them and not kind of assuming a conclusion about that. And it's so easy in this kind of experience to do that. So,
well, even beyond anecdotally, I think of like what the treatment literature would tell us. Previously the treatment literature told us that patients love telehealth. Providers, it's a mixed bag, but it used to tell us that patients really like it. And I just wonder, I don't know this, but I'm interested, I'm monitoring, and I haven't seen anything come out yet. Now that this was like a really predominant way, and in some instances the only way to receive behavioral health care for some folks, what do they think about it now? Because previously, I honestly, that's to me an empirical question. I don't know what that, I'm no longer assumptuous about what that will be, because the cohort of people who are receiving telehealth is so vastly different than it was a year and a half ago.
and I think in so many ways it's very different, right? It's the only form for some of us for quite some time, but the folks seeking may be a different cohort in terms of, who is coming on now through this year as a client versus previously. And there's a lot of variability with that. So I think the data it'll be very interesting to look at that data now as it's coming forward. So
I want to sneak in, one change I observed over the last year that I thought was really notable, for psychologists, and that is the explosion of online behavioral health offerings. So, I mean, there have always been online behavioral health offerings. I won't mention any brand names, but they're out there. And the experiences are variable. Some are great, some are less great. But the thing I'll say is that, this has long been in the marketplace, but my goodness, did a lot of them not get funded in the last year? And many of them offering licensed therapists, many of them offering coaching or other products, that are have no human component. It's digital first. And I think I want to acknowledge there's a vast unmet need for behavioral health in our country. And so there's enough for everyone, when it comes to behavioral health concerns. And, I'm not entirely sure that I know what that means for the profession, and that I, fully understand what that means for the average person receiving telemental health care in the next few years to come. So I think it's something and again, I have no great statement of what we need to be doing exactly in this moment, rather than to promote awareness that, our collegial circle is growing in this way.
well, that's a fantastic segment over to things to bring forward. And, we've learned a lot this past year, and we've also been thinking about, well, there's things we like about this that we do want to continue on. And there's also, and we won't go into this right now, but we'll come back to it. There's things we've learned that we don't really want to continue. And we'll think about what we want to leave back in 2020. But, in moving forward, like you've referenced a lot, and I continue to read in both the business side of practice and healthcare that across the board in healthcare, telepractice is here to stay. This has revolutionized a lot of things in terms of the way care is delivered. And in many ways, it makes a whole lot of sense. And so, I know we've had questions throughout the past year, will things go back to not being able to do telepractice? And I certainly don't think that's the case. Across the board, we're seeing that this has really been a disruptor to the delivery of healthcare in general, and that it's here to stay. What that will look like, however, moving forward, I think, so important if we do have options moving forward is continuing to evaluate and assess the match in service delivery to what the patient needs are, maybe to you as a provider in terms of what your needs are. Maybe it becomes one of those kind of not specialty areas, but like a specialty where some people may only be online. And we know there's been those folks in the past, but there may be a lot more now. But that doesn't mean that all patients are suitable for online services. And so there may be some changes in how we start assessing or triaging, the recommended care guidelines. And that may be at kind of our own office intake perspective. It may be at more of that managed care perspective, maybe kind of more global and researched in general in terms of those recommendations. But I think we can get back to starting to evaluate that now, and thinking about, well, is online versus in person, which might be a better match for the patient's needs. I think another piece moving forward is really seeing the dissemination of empirically validated treatment approaches, which lend themselves in many ways to service provided more easily over telehealth, out to places where providers and experts are not. And I think that access both to experts in care from more rural areas, it's making that a whole lot more opportune for folks. And I think also for collegial consultation, where, we have a different era of connecting with our colleagues as well. And I think we're starting to see how that really can play a role in all of the service areas moving forward. Ultimately, coming back to that core concept of adaptability and flexibility, we've had to shift gigantically this year. We've had to shift our software, our hardware, our technical skills. We've had to shift kind of our thinking style of how we deliver service and how much time we need to do that. And now, we're kind of doing it all, some of us, office manager and therapist and biller and everything all in one. And so keeping in mind what parts of that are something that we do want to bring forward with us and continue on. I think a lot of folks have realized, oh, there's more that I could do. It's not too bad. It can ease up or change up some of the overhead burdens and things like that within the office setting, and making the practice itself more flexible. So there are a lot of those concepts that I think are wrapped into the conversations I've had with colleagues in terms of, okay, where are we going to go next now that we have this new skill set?
These are great questions. And I think, this is really it's a compelling moment of time and a shared moment in time. Many of us transition our practice, over the years here and there, but to do it en masse and in this way, I think is a compelling opportunity to collaborate.
I agree.
Speaking of, we have some wonderful questions. You see that seamless transition, Margot? We have some great questions that have come in through our Q&A box, and thank you to those who have submitted them. I thought we'd read a few perhaps and respond. And
sounds great.
Okay. Well, here's a question that was in different formats. said, can you provide suggestions for if you want to transition to 100% telehealth and work from home, specifically in regards to publish address and what to communicate to insurance providers, assuming you have another physical mailing address, but it is not where you would see clients. There's credentialing, there's submission of invoices to insurance, there's your public listing. This is a great question, and one that I had asked of me pretty recently and had to go do some homework. So I was excited. I get to recycle the homework I did. So this is, and I hate answers like this, but it is true. It is somewhat idiosyncratic to the payer, to the insurance who you're paneled with. As a broad matter, it is typically my recommendation that you consider having an address apart from your residence to receive professional mail related to practice. And that is a pain, and I want to acknowledge that. But, and that can be a PO box. That could be, really the PO box is the best. That could be a mail forwarding service. There are other ways to approach this. But the reason I bring this up is certainly it is feasible. There's no legal issue that I'm aware of having your home address, if that is where your office is located and you have an exclusively telehealth practice. And by the way, if you want other recommendations like video conferencing platform, like setting up the physical location of your office and so forth, prior chats, we opine at length on these themes. But with regard to the address, I will say that the practice of payers in terms of how they gatekeep that information is highly variable. And in many instances, the address that you put on that CMS 1500 form, that insurance submission form, and the one that you have registered alongside your NPI in their internal database, either as an in-network provider or out-of-network provider, then becomes information that is accessible to the patient. And as this writer indicated, is listed in their provider directory. I will acknowledge that some payers are awfully hip and savvy and are hip to this issue, and they will have a separate address. But I'm aware of like one instance. I say some, like it's more than one. I'm aware of one payer that does that. So more often it seems that when you give them an address, they are working under very brick and mortar assumptions, and that information will not necessarily be protected from view of others. I want to acknowledge it's tremendously convenient to receive your mail at home and to not have to go somewhere else to pick it up. This is where I think mail forwarding services are interesting, but from just an accessible, easy, available everywhere solution, a PO box can be a very convenient, option. Some folks will say, well, gosh, it's another expense, and I totally agree with them, but it's less than rent, so that's good. So if you're an exclusively telehealth practice, just keeping that personal and that professional separate in that way do I think the probability of discovery of your home address is incredibly high to result in problems? Like, not necessarily, but it's a risk that I wouldn't take. And so I would make the suggestion that you keep them separate.
I think that's a great suggestion. I know we've had a few questions in the past as well that it seemed like some credentialers and insurance carriers did not want to accept PO boxes. So I think having a mail forward service where there actually is a physical address is a great solution to that as well. So, and you're right.
That's a great point. So, if you cannot have a PO box with that payer, mail forwarding service is good. I mean, I think it's by necessity going to end up, because if you can't use a PO box and you don't have a readily available mail forwarding services, regionally, some people are going to end up using their home address. I don't love it, and I don't know of the right solution transparently. But I would say that, as much as you can keep it separate, then at that point, what I would do is I would call the insurance company and communicate with them about what my options are. And ask, can I have it privately listed? So I think for telehealth only providers, hopefully increasingly we'll see this become an option. But right now we're kind of on that Wild West frontier where I don't think security practices have caught up with the reality of what's going on in providers' lives. So as much as you can be thoughtful about an opportunity, and if you are maintaining a brick and mortar office, but you just aren't going there as much, or you're splitting your time, then it's easy, then I would say absolutely just send it to the brick and mortar office.
I think the other thing to consider too with that is, unless it's a super small town like where I live, but in general, we're the only ones that really know it's our home address. And so if you're super cognizant about that in terms of decor and what's going on in the background, and you treat it as though it is an office somewhere outside your home, unless there's some other factors going on, it may not be as big of an issue, but it's certainly, things to concentrate on in certain patient populations.
Right.
I totally can appreciate that.
It's a risk. I'll share with you. I had an office fairly close to my home, within a mile of my home at one point in my career. And I had a patient say, "Well, I saw you walking down your front steps. And then I Googled, you have that house for a steal." And I was like, "Oh," and it was so conversational, and it was so boundary pushing. I think it does happen. If folks know an address, they may look an address up online. So, I mean, again, the probability of an issue, I don't know, but it's a risk that we're introducing when we don't have a physical address apart from our own home.
Agreed. So that's a great question. Do we have some more?
We have lots more.
Awesome.
I have a Medicare question. How do we feel about that?
All right, let's try it out.
We'll try it out. I'm not sure I know the answer.
A telehealth chat.
Apparently, we may, if we don't know the answer, we'll go look it up. And the next time we come on to our telehealth chat, we'll have an answer. Does it look like we will be able to continue giving telehealth psychotherapy with Medicare after the pandemic? What about traditional insurance like BCBS? So I'll try, and then we'll let Mara go because she's more clever than I about these things. My understanding, and I think we just had an opinion from someone I'm going to read while Margot's talking. My understanding is, yes, there's no indication at this time that there will be a reversal of the Medicare policy, is my understanding. And Margot, I'm going to pause and look at you and make sure, do you know something I don't hear?
I have not heard a flurry about it. You can go on and check in terms of, up at Health and Human Services, but it is the same kinds of recommendations we've had in addition to the states. And there's, when it relates to Blue Cross Blue Shield carrier, that's state by state or jurisdictional determinations. That's not a federal consideration for that company. So you have to look in your jurisdiction or the jurisdiction that's providing, if it's Blue Cross, but it's not in your state, look wherever the Blue Cross comes from, to see what those mandates are and what those requirements are. Or what could have happened now in the past several months is legislatures are back in session. And so there have been a number of legislative pushes for all sorts of things related to telehealth in general. And so that really is the whole point of a governor order that, makes a mandate on these things, that eventually the legislature might pass a law that supports that or terminates it altogether. So those are really important things that you want to keep your eye on locally.
Absolutely. So, these will be regionally sort of within the jurisdiction. I am aware of no trend wherein, and I would encourage people, if you're aware of a trend, if that's happened to you, put it in the chat. But from a larger scale, I have not encountered, people all of a sudden receiving denials. And we ran into some circumstances where some jurisdictions, their mandates did expire. But to the best of my knowledge, for the most part, there has been continued coverage and it has not reversed wherein all of a sudden you can't have a telehealth appointment. Now this is just my 2 cents. I'm not speaking for the trust, or I'm not speaking, for the world's insurance. I would be very surprised. I think telehealth is here to stay. And I would be surprised if there was some massive reversal, of permissions around telehealth. I think it would be wildly unpopular. That being said, I don't run the federal government, but I would be very surprised if that happened.
Well, I see we do have a lot of questions. We did have a couple things that we wanted to make sure to touch on. Do we want to quick cover those and then come back to the live questions?
Absolutely.
Awesome.
Well, you and I had brainstormed a little bit, Margot, about, the return to in-person care, since this is now more than ever on people's minds. And as we spoke about moments ago, how much telehealth do we want versus how much in-person practice do we want? What do your clients want? And have you asked them? Have we had that conversation? Although there's a saying in my household also, don't ask questions that aren't questions, but That is to say, of course, I want to know where my patients are at. And of course, I want to know, what their desires are, but I want to be cautious not to offer up services that I am not myself ready or physically able to safely give. I think, we're starting to think about our physical offices availability. Many people surrendered a physical office or reduced their time in a physical office in the context of the pandemic, and the appropriateness of that space. I can tell you at one point, I owned a practice and I went and took a tape measure every single room, measuring to see, could you possibly sit 6 feet away? Thank goodness you could in our practice. But, when we decorated, or when the associates decorated, when we chose the building, I didn't have the tape measure then. So it was just good fortune. Have we done any sort of internal cost analysis of ratio of telehealth patients we anticipate will want to serve or who want to remain telehealth, ratio of in-person patients, and what the cost of revenue is for a rental of our office space if we don't own it, for brick and mortar practice. So, have we done the financial analysis to look at, how much in-person practice do we need to do to support that expense? What does that mean? And really, do we understand the financial implications for when to return and how much to return? We have to think a little bit about our willingness to use PPE. To my knowledge, the recommendation from our professional organizations remains that we wear masks and our patients wear masks and practice physical distancing. So how do we feel about that? I've said, many folks say, I would rather have telehealth than to not see my client, from there down. So where are we with that? And what about, I have some patients who I know absolutely would not wear PPE. They're just, no way are they going to wear a mask. They feel very strongly about that. I do wear masks. And so this would, I don't really think of it as a political issue, but maybe they might, and so like, what does that mean for a clinical relationship and our ability to meet, which in my mind's eye, safely? I think this is going to start getting into our vaccination status, our patients' vaccination status, and what is our willingness to discuss our status? It is your protected health information. What is your desire or appetite for discussing that with your clients? And how are we feeling about asking our clients this information? I think that there's been a trend here in Seattle, anyway, this was written about this week, about asking, in a medical practice, people will ask, are all the staff vaccinated? Well, that's staff PHI. People can't just readily say, oh, well, I can tell you everyone except this one is vaccinated, or, this one is and this one isn't. I mean, I've seen some trends where people do aggregate reporting, but, if it's a 3-person office and they say 66%, are vaccinated, it gets a little itchy. So I think it's really a question of how we're going to manage people's concerns. I do continue to advocate for good paperwork and documentation practices. I do like that trust template consent for return to in-person care. I think it's very right-minded. And somebody put in the chat earlier, if people are using that. I'm not sure that everybody is using that, but it's definitely my risk management recommendation.
Just to jump in on that, I had seen that comment as well. One of the things that I think is really helpful in thinking forward as to, now we've got these 2 different ways that we can practice. However it is we're going to practice, your paperwork should reflect the aspects of it. So if it's, as you're updating your paperwork, which, from time to time, historically, a year at a time has been fine. You may have to update your paperwork quarterly at this point, depending on what you're offering and how you're offering services. And this idea of what are your requirements, where I live, the state law changed. So, there is no mask mandate, but as a provider, we're still required to follow the public health guidelines, which do have requirements about masks and physical distancing. And so, that gets to be confusing for patients and for families. And I think figuring out in your paperwork what's comfortable for you and kind of what your boundaries and your guidelines are with that, and you put it in your paperwork so you're reminded for yourself, but you also can be informing your patients as to what might be changing or how it might be changing.
Absolutely. So, documenting, your expectations, benchmarking around themes like PPE use, like social distancing. If you have a specific check-in procedure, relevant in the pandemic that's new, or, many people don't have a waiting room anymore, or they don't want people in the waiting room, and just as we used to do with telehealth back in the day, where we'd say, we're going to try it out. We're going to see how it goes. I would encourage people to benchmark the expectation that you have not committed to always seeing them in person for the rest of care, but you're going to try it out and see how it goes. And if they show up, visibly ill, or things that you're just like, oh no, that's not working out, you may make some changes. I know some offices are implementing temperature checks, and this is something they've done in the context of the pandemic, and they'll continue to do at this current stage. So really figuring out, helping the client understand what they can expect when they come back to in-person care, because it's probably going to be different than what they recall if you've been telehealth for the last year. And I'll say now that if you are moving forward and you're requiring PPE, consider offering some, and having that available in your office. I would say order it now. I've noticed that, it's again becoming a little bit harder to come by some of the supplies. So I do wonder, as we see ramping up of return to in-person work and school and services, do we see again a little bit of challenge? I'm not saying we should all hoard toilet paper, again, but buy what you need, I would say, and have it available. And again, I'll put in a plug that thankfully we are able, through Amazon Business, to access PPE. We are able to set up a business account through Amazon if you give your MPI, and you are able to order PPE as a medical professional.
Kind of related to that, Sarah, is one of the questions I'm just going to toss out right away to you, put you on the spot. But when I return to my office-based practice, am I within ethic and legal grounds to ask my patients to show proof of vaccination card? Whew.
It's a great question.
That's a good question.
Yeah.
My initial reaction came very quickly, which is, I guess, to the extent that you trust the card or what they're showing you, right? That, it's not a driver's license. It's a card that we see a lot online. And I've actually wondered this myself in terms of just if to travel, we have to show a proof of card. The federal government is, to my knowledge, not accepting just those cards. There's this World Health Organization certificate book that they are looking at for some of the federal institutions. So I think there's a lot to think about related to both is it valid and ahead of even the legal or ethical consideration of, we've never asked for those kinds of things in the past, and it's not our job to know if it's right or wrong or accurate or not. But to the extent that you're going to rely on that for your secure office space, or maybe secure isn't the right word, but your healthy office space, I think you really have to kind of dig a little deep into that question.
I mean, I'll share, I will be asking. And I know that's fraught. I know there are folks who think you shouldn't ask. And, I'm not aware of any legal reason not to ask. And that to my knowledge is not so different from asking if you've had a measles, mumps, or rubella vaccine, or, some of the criteria to go to school or to travel to another country. Some of these things are routinely asked. I agree with you that I am not a connoisseur of medical documentation such that I would know a fake vaccine card from a real one. I think, I hope, I won't even opine as to what folks may or may not do. But, I think I will be asking. I understand why people feel differently on this, and I appreciate that people can be not truthful. I think people can be not truthful about all kinds of things in the therapy room. But this is high stakes poker because it has implications for everyone's health. And so I assume moving forward, there will be, some, I hate to say this, there's going to be some way in which we are verifying some of these things. For now, the best, documentation I am aware of and would have access to is that vaccine card. Moving forward, we may have something a little snazzier and more advanced, but I'm always kind of bearing in mind that balance with people's autonomy and their willingness to share that information.
Well, I think equally are we willing to share it as the provider, because we may be asked as well. And I think that's another thing to consider in the ethic and legal side of that, how comfortable you are in that as well. And historically, that's not been, that's a protected health information, just like you said. And while we're used to dealing with it from the patient side, there's no no assumption of confidentiality on our side now, for us sharing our stuff with the patient. And so it could be the office, what can we actually legally share for our office staff? These are all really important questions to be thinking about. It's not a quick, oh, I'll just show my card factor.
Absolutely. And, I think from my perspective, we are asked questions that challenge us by patients all the time. I'm asked questions about my marital status or, my religion or my sexual orientation or things that I'm like, I may or may not want to share in the context of a clinical relationship. That would all be qualified under the rubric of PHI, if it were written down in my medical file, and this too is my private information. I think the way I feel about it sort of bilaterally is like we both have to be okay with saying no or someone else saying no, but also then live with the consequences of that. Because if someone comes to me and says, what is your vaccination status? And I say, I decline to tell you that, then that may very well cost me the opportunity to continue or to initiate that clinical relationship. And I'm not saying that that's a reason to do it or not do it, as much as that seems like a possible consequence.
Sure. And I think that's, for me, just another aspect of why I would choose potentially to continue on with, physical distancing and mask wearing and all of that within my practice, that I would just assume, how can we figure this out? So just in case, we're still all practicing in a safe way and it's a healthy work environment for the employees that are here.
Because unless you're an adolescent, with a Pfizer vaccine, the efficacy data is not 100%, right? So, the reality is someone could be, completely vaccinated 2 weeks out, and it's not impossible for them to have, the COVID-19 virus. So I think that, this just highlights like, this is always a risk. It's a question of how we're balancing it, and where our own tolerances and the tolerances of our clients reside. I'm observing the time. It is 2:50.
I want to make sure we get to the conversation about insurance carriers real quick.
Yes. Last time someone came on and said, well, what about when insurance carriers make you use a platform? And I said, oh, does that happen? I have not. And folks said, oh my goodness, yes, this happens. And I went and did some homework. And oh my goodness, yes, it does happen. So what I learned a great deal about this in the last few months, there is a growing trend, particularly in the Southwest, wherein there are payers who are requiring the use of pretty darn idiosyncratic video conferencing platforms. And these are not always like the big ones that you think of. These are not always, Zoom for healthcare or Simple Practice. A lot of times it is something owned and operated by the payer or by the healthcare system, in which the payer is working. So, this is requiring an additional level of training by the provider to come in and really learn this new system, to participate in the system if they want to see these patients. So this is absolutely something that's happening, and it does look like the payers are able to mandate this in order to participate in their panel and to see their patients. So it is definitely a trend. It's something to be on the lookout for. It was something I had never heard of, but it is something that's absolutely happening to folks.
Well, and Sarah, I will follow that up with having a conversation with a provider in Virginia, where this was also one of the things that was kind of starting, but apparently enough large providers were not able to get on board with that the conversation had really transitioned back to insurance carriers not requiring that. So, I think it's an interesting phenomenon that we'll want to pay attention to and continue that conversation through our next chats.
Yeah, I saw a few questions here that I'll do. Should I do one more and then we'll? Okay,
sure.
That's a really good question. I hear folks saying, well, hold on. So it's okay to decline seeing someone who is not going to be vaccinated, or it's okay to say yes or no, vaccine or no vaccine. This to me is where telehealth really comes in. So I can think in my own practice, I'm a cancer survivor. That's important to me. I'm someone who really is high risk. And so, depending on my vaccination status and my own risk tolerance as a person, I may be in a circumstance where I don't want to work in the same room with folks who aren't vaccinated for a while because I am so high risk. I think what I feel really good about as a provider, because I don't like the idea of not seeing someone if they're not vaccinated. That feels ethically poor to me. That's not to say that everybody should do it. I'm just saying that, like, for my own practice that feels difficult. The fact that I can see them over telehealth and that I know there is a really sound literature that they are going to have comparable outcomes, that we have the opportunity to have rapport, that I can do this ethically and clinically appropriately, to me is just a lifesaver. So like possibly literally. And so for me, I'm not opining as much like see them or don't see them, but I am opining I might, be routing folks who don't want to disclose vaccination status or have decided not to receive the vaccine, or I myself am high risk, or I decide not to receive the vaccine. I may be, shifting more of my practice to telehealth until such time as we really have widespread vaccination. We're at about like under 20% in my state currently. So we're really not there yet. So, in that instance, I may be much more inclined to work with that person remotely, and just kind of watch the data until I feel like public health safety is in a better place.
I actually feel that this conversation is in some ways not hugely different to areas of practice that you're not either competent in, or you're not comfortable, or it's not a match for you to treat. Doesn't mean that you wouldn't know how, but that maybe your personal circumstances are such that it's not a good idea for you to treat a certain type or clinical issue at the moment. And so, we're not anywhere when we're given a license to practice psychology, we're not obligated to put our life at risk to practice psychology. That is not the kind of thing we're signing up for here. And we should be cautious about our own perspectives in that not kind of impacting the care that we're giving. And if we're uncomfortable or not sure, then we do have to kind of modify what it is we're doing in our practice. And that's one of the things we started talking about at the very start of the hour, of just that flexibility and adaptability. And so while this is one of those relevant experiences for everybody, how it's impacting us personally, professionally, can be so varied and so different. And I think that really is the piece for me that we have to have an internal awareness of, and we may have to shift what our practice is and how we're doing it, whether it's online or not at all, or some combination of what we feel comfortable. Maybe it's outdoors. Like there's so many more opportunities to be flexible now, and I think making sure that we're making decisions for the right reasons, and not because we feel, because we're licensed to provide care, we absolutely have to provide care no matter what, or because if we choose not to see folks because they're not vaccinated, that would be some big giant legal issue. It all comes down to what you're comfortable with and what you're capable of in terms of that practice. And that's volume, population, it's how you're doing practice. It's related to a lot of things, not just COVID and a vaccine.
Well said. Well, and my opinion that we should all become school refusal experts immediately.
Yes.
It's coming. Well, we're about at our time, so I'm wondering if we should put our slides back up now and review some of our closing information together.
Well, Sarah, I want to just say we could probably have another hour. There's just so many continuing aspects to this conversation. Both we see a lot of interjurisdictional questions, which you can go back to some of the past telehealth chats and learn more about there. But it's such a delight, and I'm just so grateful. We've got a few more on the books this year to come back and continue our conversation.